Thank you very much. It's great to be here. So to start,
Just, yeah,
Yes.
green button.
the green button. The green button. Yeah, great. So I have some disclosures. Basically, we'll work with anyone who'll work with us. The session before the trade show outside shows that we have loads of tools to do operations with, but still surgery requires decision making. And to look at this significant polyp, I mean, this is what if you're doing colonoscopy, you might encounter this. You may have been expecting it, you may not have been. Who here knows this is definitely a cancer? Or who here knows it's definitely not a cancer? Because that's the jeopardy. It's not so much the identification of these big lesions, it's the characterization of it. And in the time I was asking those questions, I'm going to show you an AI system that we think tells us this using ICG. So currently the clinical state of the art is that endoscopy can find lesions, but characterizing them in that moment is difficult, both by clinical assessment, including spectral mucosal analysis. Biopsies, once they get to 2 centimeters, are only about 80% accurate, and MRI or EUS often can't be done at that time, but is anyway only about 50% accurate. So just detecting it is not classification of it. Now, we had a lovely talk just before from Dr. Jafari about ICG and perfusion, and you can quantify the signals. So the screen goes green at different rates in different places, and you can take curves off it to show how those things go. So you can start to quantify the greenness of it. And we're just going to show you this is the small bowel is going to go green now in a moment, and the large bowel, and you'll see the system is going to take curves from those different areas of the screen. And you can compare then different areas of the screen as to how they're going green at different times and different rates to it. So this we think is useful. So vascularity is different in cancers compared to not cancers. There's lots of other differences too, and basically every paper you've ever read tells you that cancer is different to not cancer, but an early hallmark of it is changes in the vascularity. And this dye linked with quantification can exploit those differences in real time. So comparing regions of the screen, things that are abnormal compared to things that are normal, every patient acting as their own reference point, you can see that there are different perfusion patterns in a cancer compared to normal tissue. This is like how diffusion MRI works for breast cancer, although the curves are a little different because of the type of tumor and the type of vascularity in it. So yeah, this is what we're doing. We're taking endoscopic pictures as a time series, comparing a normal point on the screen to an abnormal point of the screen, and looking at the differences of flow of the ICG through it. That gives you the graphs, but importantly, you want to make some interpretations of those graphs. You want to classify the differences of the graphs. There's lots of significant differences between them. Basically, the tumor is slower to perfuse than the normal tissue to it. But we are looking at milestone differences along those graphs to it. Not just is it cancer or not cancer, but you can start to draw boundary maps of the lesion as well. When you're doing local excision of rectal cancers, there's about a 20% positive margin rate, and so delineation of the lesions is also possible using this way. I mean, we think it's possible. This was a 100-patient series that we did between 3 centres, 2 in Ireland and 1 in the Netherlands. And you can see at the bottom really quite impressive sensitivity and specificity of this. Particularly importantly too, that type of technology corrected for 12 out of 16 false negative biopsies. So we're getting kind of a 92% accuracy overall compared to the clinical state of the art of 79%. Now, it's kind of encouraging, but it's relatively small series. So this is what we're trying to do now. We're trying to validate the concept, show it's generalizable outside these populations, build a more robust software method that would allow it being done in real time, and develop the protocols and training and guidelines to try to make sense of this. So this is the Classica study. This is an EU-funded project. We're nearly at the halfway point of it, and we're lucky to work with 8 leading cancer centres in Europe, one in the UK, which is now not in the European Union anymore. But also importantly, with a number of non-clinical partners to try to consider how this might work or make sense of it. So that includes some of the legal and liability issues, and also training and clinical implementation steps to it. So it's split into 3 clinical studies. The first one is the validation of the general mathematical principles, and we're just concluding that now. So that's trying to see, does our initial mathematical concepts still hold in a bigger patient series from more diverse patient population groups, and it does. The next 2 studies are the more interesting ones. This is when we're going to deploy the software in real time, and we've had to build out the software to a regulated clinical device in order to do study 2 and 3. So that's where the first 2 years have been spent. But now we're going to run it in real time and look to see, can it either guide the biopsies or even obviate the biopsies by its accuracy of anomaly detection in the lesion, and finally end up with a small but significant randomized trial looking at the tissue margination, surgeon plus AI compared to surgeon alone. So this is how the patient recruitment is going. It did take about the best part of a year to get all the centres open up, but they are all recruiting now, and you'll see the projected rates means we will catch up with those lengths because we've expanded our clinical series a bit more. It certainly seems reasonable to patients that we might give them a dye, and it's reasonable to the surgeons in the operating room that the extra couple of minutes isn't difficult to do. But the deployment of the software to allow study 2 will happen this month, actually. We'll have the software in April to build it out. So far, this is the annotation software that we're using to capture the data from the different centres coming into place. So they upload the video and some patient details, then get anonymized in the cloud, and this is how we've been doing the mathematical assumptions for it. This gives us some hint of the software performance. So when you're tracking different parts of the screen, it's important to make sure that what you're getting back is true and reliable. So the quality assurance system of the software, dropping out areas that are no longer reliably being tracked, for instance, is an important bit of the software engine to try and make sure that the curves are clean, robust, and reflective of the tissue differences to it. So I'm going to stop there. We're getting to the kind of the really interesting bit of it to see, can this be true and useful? It is an open study. It's predominantly European by its funding nature, but we'd love your thoughts. If anyone would like to collaborate, any ideas or concepts, be really welcome, because this is the right stage, because it's a malleable project at the moment, and it'd be really great to try and get this right in the next 2 years. So many thanks for the invitation and the opportunity to present this.
Thank you.